A very good evening and a warm welcome to all the doctors present here. I am Devolina from Clearnet. You all know that Clearnet is India's largest live digital CME platform, which is exclusively free for all the medical practitioners. So now I would like to play a short glimpse of Clearnet that I would like to share with all of you. Thank you so much all for your patience, and you all are invited to visit our website, which is www.clearnet.com. So now without further delay, I would like to hand over the session to Dr. Kia to start with the scientific program. Over to you, ma'am.
Thank you, Devolina. Thank you very much. A very, very, very warm good evening to all of you. And without any further delay, let's start. Today, we have a scintillating session. We have scintillating sessions with stalwarts of the field being present here with us as speakers, chairpersons, chief guests, and guest of honor. Our speakers today are covering the very important topics like MHT and MHD in comorbidities, which are the need of the hour, which we all agree. So let's start the session. Let me please first invite the president of Agra chapter of Indian Menopausal Society, Dr. Ratna Sharma. Dr. Ratna Sharma is director here in Ashirwad Hospital, and she is a through and through Agra alumni. She is practicing here for last 32 years. President IMS Agra right now, past Vice President IMS Agra, past Cultural Secretary IMA Agra, and has been a chairperson and judge in many conferences. And she's active in her social and academic fields both. Ma'am, please welcome. Dr. Ratna, ma'am. Ma'am, kindly
unmute yourself. Still muted.
Now?
Yes, ma'am.
Yes, Priya. Good evening, everyone. I welcome you all from the bottom of my heart. I'm feeling very happy to have all the high authorities of IMS today in this webinar. Our motto of IMS is fit at 40, strong at 60, and independent at 80. To accomplish this, we should now learn menopause, which is not a disease, but a change of life, which transforms the woman life. Many women are likely to have remain asymptomatic in menopause, but vast majority has a negative impact on their lives. So, to make them independent at 80, we as a doctors should learn every aspect of menopause, starting from symptoms to investigation to diagnosis to treatment, and especially about the drugs, what to use, when not to use. So, to clear our queries, we have Galaxy of Star Wars with us today. Now, without wasting time, I welcome Dr. Ambuja ma'am, who is not here, but now I request our Dr. Savita Tyagi, who is a soulmate of mine and a very dynamic person. She is at present chairperson of Rural Committee IMS and secretary of AOGS. She has been founder member of Agra Menopausal Society. She has been invited faculty of FOXY in IMS Con. She is active member of NGO of Hum Saath, and she has a keen interest in infertility and midlife treatment. So I welcome Dr. Savita Tyagi to welcome our esteemed chief guest, Dr. Jignesh Shah and Dr. Sudha Sharma ma'am.
Thank you so much, Ratna ma'am. First of all, I am thankful to all of you, Agra Menopause Society, for inviting me over here, and I am also a part of this society, and I'm so much happy. Dr. Ratna is doing wonderful work. Today also we did one camp in the rural area, and I think that is very much important for this IMS family. And first of all, I am really thankful after so many months. Today, Dr. Jignesh is here with us. We were missing you, sir. After you left as a president, you disappeared from our this society's main platform. You never joined this because you were abroad at that time, I think so. Thank you so much for joining today. And this sir is a senior of gynae practitioner in Ahmedabad, practicing since 37 years. Vice President, Indian Society of Perinatology and Reproductive Gynecology. And yes, he is the past president of Indian Menopausal Society 2020-21. We all know him very well. So many these webinars you started, sir, and that which was also started by you. That was very much appreciated. Each member of the IMS, everybody were used to doing that quiz in the Sunday in the afternoon and were asking why. Sometimes once I forget that quiz to be released on the platform. So all members used to ask why this quiz is not there. Thank you so much. You are the for doing so wonderful work during their tenure. You are the past president Ahmedabad of Gynae Society, life member UHGS, IHE, SAR, SPAR, organized number of state and national level conferences and workshops, invited faculty for state and national and international conferences, special area of interest, high risk pregnancy, infertility, menopause, and fetal medicine. Center is recognized by FOXY for basic and advanced USG training. What to use for your kind words?
So thank you, Savita ji, for all these kind words. But I will say now the introduction should be only two-liners, not much. And in our profession, if we do not consider our family at first, then we are the losers. So after finishing my tenure, I concentrated more on my family and profession. And again, I am back to my this extracurricular activities. So thank you again. Thanks for the invite. What happened? Hello?
We can hear you. There's nothing wrong.
Yes, sir. You are audible, sir.
Okay. So I congratulate Agra Menopause Society, especially
Sir has
No, we can't hear you.
Sir has disconnected, ma'am, I think.
Yeah, I think so.
Sir, connection lost.
We can continue, ma'am.
Continue, Savita, you welcome,
Yes.
Sudhaji.
Can we proceed further? Our second chief guest is Dr. Sudha Sharma. It's my privilege to introduce our smiling Dr. Sudha Sharma, madam. She is a former professor, PG Department of Obs and Gynae, GMC, Jammu, Secretary General IMS.
Dr. Savita, that's enough.
Very
Very
it's over
rightly
to you,
said by
ma'am, for
Dr.
your
Zeenil.
kind
Just two
thoughts.
lines. Yeah, yeah.
Yes, so humble, madam.
Good evening, Agra. I really want to congratulate Dr. Ratna for organizing this and inviting all of us over this
Thank you.
platform.
Thank you.
Dr. Savita, Dr. Aarti, and the whole Agra Menopausal Society. It's so lovely to see all the friends on this platform. Dr. Shobna, even not feeling well, even then she has joined it. So good to see you, Dr. Shobna. And you know, the topic chosen is so very important, MHT. The more we talk about it, the less it is. And every time we read about it, we always learn a new thing. And you have invited a galaxy of stars. I'm sure we are again today going to learn more and more about it. So all the very best. And thank you for making me a part of it and inviting me over here. Though I am traveling, but I thought it is my proud privilege to, to be a part of Agra. Thank you so much.
Thank you. Thank you, ma'am.
madam.
Thank you, ma'am.
Jignesh
Thank
sir
you,
is there. Yes, sir. Yes, sir. Yes. Sir, you are muted. Yes.
So my best wishes to today's webinar, and I'm sure it will be helpful in spreading the uniform message about the management of menopause, especially related with menopause hormone therapy. So thank you again for inviting me, and my best wishes. Thank you.
Thank you, sir. Thank you, sir. Thank you.
Thank you, ma'am. Thank you, sir. Thank you, ma'am. Now, may I please invite Dr. Ratna, ma'am, to welcome Dr. Shobna, ma'am.
So, again, it's my proud privilege to welcome our President IMS, Dr. Shobna Das ma'am, who always bubbles with knowledge, and she's ready to create a history in her presidential year with her work, with her knowledge, and with her dedication. She is a proud president of IMS for the year 22-23. At
Yes,
present, she
that's
is
enough,
working.
Ratna, madam.
मैम आपका इंट्रोडक्शन तो सबको पूरा ही मिलना चाहिए.
आपको तो पूरा बताना है डॉक्टर शोभना. लेट पीपल
अरे
नो.
कितना बार सुनेगा
हाँ.
अभी ये सेम. चलेगा अभी. I will go to my presentation.
Okay, okay. Should I continue, ma'am?
No, no, no.
Acha, okay. Thank you, ma'am.
Ma'am, shall I invite the chairpersons then?
Yes.
Okay. Now, may I please invite our chairperson for first session, Dr. Sudha Bansal, ma'am. Dr. Sudha Bansal, ma'am, is senior consultant in SR Hospital and director of Katyayani Healthcare Private Limited. She is past president of AOGS Agra and very socially and academically active. Going with the norm that we are just introducing in 2 lines, I welcome Dr. Sudha Bansal, ma'am, again. Welcome, ma'am. Ma'am, you have to unmute yourself, ma'am. Yep.
Hello. Hi. Kia.
Thank you, ma'am.
Again, unmute.
Ma'am, you are getting constantly unmuted.
Hello. Hello. Hello.
Hello.
Yes, ma'am. We can hear you.
Madam, you are audible. Just carry on.
Yeah. There is some problem. You just welcome Dr. Richa Singh.
Yes, ma'am. I
Just
also invite,
ask her to put her video off. I think there's some net connection. There's net connection. Ask her to put her video off.
Call her. Na? Okay, okay.
okay. May I please invite Dr. Richa Singh, ma'am? Richa Singh, ma'am?
Yes.
Hello.
Good afternoon, everyone.
Good afternoon, ma'am. Dr. Richa Singh here is professor in Obstetrics Department in SN Medical College, Agra, and her laurels are quite evident by the fact that she is a recipient of Best Teacher Award given by students of SNMC Agra. She is past Secretary AOGS, past Vice President Agra Chapter IMS, Organizing Secretary UPCOG and AICOG, and has delivered many orations in many state and national conferences. She is also recipient of many awards, including Foxy Korean Award and Karan Gupta Award. Welcome, ma'am.
Thank you, Kia, for your words of introduction. And I take this opportunity to wish good evening to all the stalwarts who are present here. And it's my privilege to chair the session being taken by Dr. Shobna ma'am and Dr. Anju ma'am.
Can I start now?
Yes, ma'am. Eagerly waiting for you, ma'am.
Is my slide share visible?
No.
No, ma'am, not yet.
Now?
No, ma'am.
Okay, I'll do it again. Now?
Yes, ma'am.
Yes, ma'am. Yes, ma'am.
Visible.
So the topic today is MHTI. I had prepared this for hot flashes, but basically MHT is used for premature ovarian failure and osteoporosis also, and the protocol doesn't change much, except that if a person with osteoporosis has got hot flashes, you do give estrogen, and that will also help in bone formation. So basically, there's not much difference in the treatment, for osteoporosis per se. But if there is no hot flashes, bisphosphonates is good enough. That is also there. But these are the other indications for MHT. This is just what I want to start. The hot flash is the main reason why people do take MHT, and it comes with palpitation, vertigo, weakness, lasts for 5 minutes. But you have to make sure that they're not taking any drugs, and it's, amlodipine and things like that also cause heat. So you have to differentiate between that, and only if the person has got real hot flashes, you give MHT. When there is an aging process, there is fluctuation of estrogen levels. And when there is fluctuation of estrogen levels, the hypothalamus gets confused, So the receptors are like, there is a destabilization of the thermoregulatory set point. Total confusion, estrogen coming up and down, up and down, up and down. And so because the set point is kept below, you start feeling hot faster. Along with that, external factors and everything also helps, but it is basically the fluctuations in estrogen levels. Once it goes to a nadir in late menopause, then it doesn't matter. But when there are fluctuations, you get hot flashes. If it is fluctuations of estrogen, then you have to give estrogen. And it has to be given when there is estrogen given. To protect the endometrium, you may have to give progesterone or a molecule like tibolone or vasodoxifene. I will explain all this later on. So first of all, if there is no uterus, you can just give estrogen, either it is conjugated estrogen or estradiol valproate or estradiol other molecules, 1 or 2 milligram. If the uterus is present, then you have to add a progesterone to prevent endometrial proliferation, and that has to be done with either medroxyprogesterone, norethindrone. The favorite is medroxyprogesterone, but nowadays we are saying that it is better to give dydrogesterone or micronized progesterone. This has to be given as cyclic or cyclic combined. Cyclic means last 10 to 14 days of the month you have to give progesterone, or cyclic combined where you give it up to from 1 to 25 days. This or continuous cycle or continuous long cycle. These continuous drugs are available only with one company where you have both estrogen and progesterone continuously. So that is good for not getting headaches and things like that. The fluctuations are less than that, but only one company has got this product. Otherwise, everywhere you're giving cyclic drugs where you give estrogen one and then progesterone in the last 10 to 14 days. And so this is just for the sake of students. So what is conjugated estrogen? Equine estrogen, we know it's taken from the mare's urine. It's a mixture of estrogens, and that is the first one which came in the market. Then came the 17-beta estradiol. It metabolizes to estrone, estriol, and estrogen sulfate. And estradiol valerate is esterified form of the natural molecule. It metabolizes again to beta estradiol, valeric acid, estrone, estriol, and estrange sulfate. So these are the molecules of estrogen. Now the one which you have in OC pills, ethinyl estradiol, that is very strong. It's very potent and it lasts a long time because it doesn't get hydroxylated fast. And so it will last a long time, but it will also have more side effects. No? Now, oral estriol, when we were all students, it was available, but it is a weak estrogen. It may not be enough. So what about OC pills? Why can't you give OC pills to everyone? One COC pill, that is 20 microgram of estrogen that it contains, 5 that is equivalent to 4 tablets of conjugated estrogen. 4 tablets of your whatever other tablets that you have. So one OC pill, when you give, that much of estrogen is there in that. Therefore, you have to avoid in women who smoke, are obese, have migraines, or have hypertension because it will cause clotting. That is why, like, the easy way of giving OC pill is not all that good, but that is there. But we all take that path. So what is equivalence of transdermal estrogen? That is one thing what I want to say. 1.5 milligram of estradiol gel contained in 2 meter doses is equivalent to 1 tablet of conjugated estrogen. Okay, when you take 2 meter doses of that estradiol gel, 2 companies have got it in India, so it is available. What about the vaginal estrogen that you have? It is containing very little estrogen, so it doesn't even require progesterone supplementation. 0.3125 only, that much it has got. So the vaginal estrogen that you're using does not require any progesterone supplementation to prevent estrogen action on the endometrium. So that is how it is. And so now, a minute. This thing is coming in heavy. Does not modify the markers of coagulation. What more favorable effect on serum triglycerides, does not increase the incidence of stroke, and eliminates it because it is applied on the skin. It doesn't go to the liver. So much lower doses of HT will successfully alleviate the symptoms. So these are the advantages of transdermal ones. But you have to sacrifice your sari or jewelry or whatever because it is pretty costly. So you let go of all the saris and all, then you can use transdermal estrogens properly. That is how you can, tell your patients, like, so what? You don't use your sari, buy too costly a sari. Thoda kam daam wala le lo, or ek se chala lo kam. Then you can use a more healthy estrogen, right? So, but it will give a more consistent level of hormones and no increase in SHBG, and thus does not reduce the bioavailability of testosterone. And it is also useful in women with diminished libido. So these are the advantages of transdermal estrogens. So this is how you apply it. 2 meter doses are taken and just put in your hand and you apply in the whole hand. Sometimes 2 meter doses are not enough. You have to apply it 2 more meter doses. So you have to give progesterone in the last part. That is there. So this is how transdermal estrogen has to be applied, and it is available in India. So 1.5, this I already told you. For mild symptoms, 2 meter doses are enough. And the tube will last 26 days. So no inherent health hazard. It affects the quality of life, and sense of inadequacy and loss of confidence will be there. Now, so the top one is just not seen. I'm not able to see the top slide in my. So what are the indications for the transdermal route? When will you spend that extra money? When your cholesterol level is high. Quite often cholesterol level, everybody's cholesterol is bad. Migraine, diabetes, controlled hypertension. But if you have a hypertension, better to use transdermal. I had a patient with diabetes whose diabetes was not getting controlled. And she was a rich lady. So when I gave transdermal, the amount of insulin that you require also decreases. When HRT actually reduces the level of, it gives you better control of diabetes. So it's better to give triglycerides in those patients because she's got hypertension. She's admitted for insulin treatment. All those patients are there. It is worth trying this transdermal, especially to your, people. What is a referred cases from physicians and all, you can use this. Obesity, smoking, previous VT will get scared to use estrogen only, but add hot flashes, maybe you can try this one. Varicose veins, bowel disorders, where of course when you have a bowel disorder, oral estrogen won't get absorbed. You want to go to the toilet every time you want to write an exam, such people, you have to use transdermal. And it's not moving. Not moving my slide. What's happened? Don't know what went wrong. Okay. Now, what about progesterone? I already told you that it protects the endometrium and there are various progesterones. So what is the difference? The dosage is MPA 5 milligram, norethistron 1 milligram, norethindrone 2.5, dydrogesterone 10 milligram, and micronized 300. So this is the dosage for all the progesterones. So why is progesterone the one which is causing breast cancer? It's not the estrogen, basically. Even in WHO trial, they showed that the estrogen only arm had less cancers. Progesterone is there in the alveoli. Estrogen is there more in the ducts. And where do you get the cancer? In the alveoli. Not much. Duct cancer is much less. So it's basically the progesterone which acts on the alveoli that causes cancer, not the estrogen which acts on the duct system, because all the receptors are out there on the ducts. So the paracrine mode of proliferation, autocrine mode of proliferation, all that will alter the receptors and give the chance of breast cancer, not to everybody, but. So what about the type of progesterone? It's not the same for all. So without androgenic properties, you do have drugs like natural progesterones, micronized progesterones, drospirenone and dinogest, and even your dydrogesterone. So again, the sari thing helps, even if it's costly, it's good to use all these things because your bloating will be less and you won't feel the abdominal discomfort. Otherwise, progesterone patients say, their blouses are not fitting them after using it for some time, because then the body starts getting bloated up. So all that things will be less, and because less androgenic if it is there with it. So this is again higher with medroxyprogesterone acetate, levonorgestrel and norethistron, lower with dydrogesterone for greater than 5 years therapy. There is better sleep with natural progesterone, and in fact, if you have decreased sleep, you use CE with progesterone, studies have shown that you can get better sleep. One thing is that the hot flashes is gone. Second thing, this progesterone is much better. So even now newer things are coming where you can even apply vaginally. Twice weekly progesterone agile applied vaginally. Lesser dose required to act on the endometrium. So of course, people don't like to use it vaginally because they find it messy, but yes, less dose is required. That is very important. And more drug reaches the uterus through a good network and lesser systemic side effects. So once in a while, if you insert it in the vagina, it's worth it because all the side effects are less. Now, with estrogen and progesterone, everything was going smooth till it struck an iceberg called the WHI trial in 2002. What happened? They had 4 arms, where they gave only diet, calcium and vitamin D3, HRT and HRT without progesterone. And they found that the incidence of breast cancer, stroke, myocardial infarction, everything it is increased because they had given it to people who were above 60. Hip fracture, colonic fracture, CA and all decreased, but the wrong age was given. That is why all this happened, and then the trial had to be stopped. But some other things were found, what? There was no increased incidence of breast cancer in the estrogen-only arm. I told you, why that happened, because it is a progesterone basically which causes it. And again, my slides are not moving. Okay. So if a 60-year-old woman comes to you first time that we heard that you're the Menopause Society lady, and we heard you give MHT, and I've come because somebody told me, and my mother has got hot flashes. Will you give it to that person's mother? Estrogen, she also has got osteoporosis. Will you give it? You cannot give it because after, oh God, it's not moving. Oh Lord, something is wrong with my slide. Basically, because after 60, the plaques have already formed. I don't know why my slides are not moving. Can I stop share and come back?
Devalina?
No, she can't do anything because I'm sharing
Yes.
from my end. My
Yes,
computer, the slides are not moving.
Yes, ma'am, you can share again. You can try sharing again.
Yeah, I'm doing that. Yeah. So, no, it's. Okay, I'll show it without the slide change.
You can do one thing. You can click, please make it a full screen and then
If I
click
make it full
right click.
screen, no, it's not moving.
You can use the another option like right click next slide.
Right click, next slide. Okay.
Yeah. Next slide.
Okay.
Yes.
So finally, what is the age where you will not give HRT? So 60, I said no. So what is the age? Either 10 years after menopause or 55 years. That means if you have your menopause at 55 years, you can even give it at 65. That's all. That. Don't fight with me. This is all common sense. So why are you giving it to 65? You don't ask me. That is how it is. And so in less than 50, the benefits of MHT far outweigh the risk. Between 50 and 60, the benefits outweigh the risk. More than 60, the benefits equal the risk, and after 70, the risks are more. That's what was shown in the WHI trial. So the way I see it, if you want the rainbow, you gotta put up with the rainbow. So MHT started beyond 60 can cause coronary heart disease. Oral MHT can increase the risk of venous thromboembolism. MHT may increase the size of already present lesions. That means if you already have breast cancer, then only it will increase. It will not cause de novo breast cancer. In fact, you will find out that you've got breast cancer faster because you are on an MHT, because you will live longer because it will show it out. You know, it's better that way. Risk of gallstones, cholecystitis, and cholecystectomy is increased. You will give more cases to the surgeons. Surgeons will be happy. But is fear of cancer with hormones overplayed? Basically, in 2008, they said that EPT associated with increased restriction, as I told you, it does not initiate the malignant change. It only increases the cancer that is already there. And all types of HRT will not cause the breast cancer. And only with the progesterone, 1 case per 10,000 can be increased. That is not a very big amount. 8 extra cases per 10,000 per year. That is not that much of a risk, right? 10,000 women, how many people give in a year? So that risk is less than the risk caused by drinking alcohol, taking all sorts of lack of exercise and getting obese. The risk caused by all this that will lead to your death is much less than the risk caused by taking HRT for MHT. So basically speaking, this is nonsense to say that the HRT will cause cancer, but alcohol will not cause anything to you. But when you give a patient all these drugs, mild GI symptoms, like in our PG days, if you don't remember anything, write mild GI symptoms, that's good. You'll get your mark. Painful tingling and swelling of the breast. Some patients always say, one guy told me, Madam, I'm getting swelling of the breast. What do I do? Endometrial bleeding. 1 or 2 cycles you give and you get a phone call, doctor, I'm bleeding. Headaches may increase, change in liver function, and there is even a risk of acute pancreatitis. That is 78 weeks later. That means you will forget that she's on HRT and then she comes of pain in abdomen. You will forget that she can be pancreatitis. It doesn't occur to you. You don't think of it. So increased factor VIII can increase risk of deep vein thrombosis, dry eyes. Oral estrogen can cause more triglycerides, but transdermal, I told you, will decrease triglycerides. Melasma, all these things are there. Drug dependence. You take HRT for a few years, they just can't stop it. They're so happy with it. That is also one problem. After 10 years also, they don't want to stop it. They're so addicted to it. This happens to many patients, especially the surgical menopause patients. Now, which one to change? Breast tenderness, bleeding, you reduce the estrogen dose. Irritability, depression, water retention, reduce the progesterone dose or change the progesterone. Breast tenderness, either you can change estrogen and progesterone, and restrict salt intake, cut down on coffee and chocolate. And fluid retention, again, low dose progesterone. And you can switch over from a systemic progestin to a LNG IUS. Even low dose LNG IUS are available abroad, called Skyla or something like that. Even that is enough actually, but we have only the high dose LNG IUS. That may also be enough, I suppose. Change to continuous combined EPT regimen. I told you it's available with one company. More water, less salt, caffeine, alcohol, and or change to Tibolon. See, there is a preparation with just 2.5 milligram of dihydrogesterone and 0.5 milligram of 17 estradiol. Sounds like homeopathic dose, no? Such a small dose both are, but still in a study it has been found that it is effective, well tolerated, and no bleeding, and it protects the endometrium. So your patient doesn't have to call you in the middle of the night saying, I've got bleeding. So this is easy, and it is effective according to them. So again, mild GI symptoms, take estrogen at night, lower the dose. Suppose we stuck with estrogen progesterone all the time, just like this cave people, you eat, just get a lot of plenty of exercise, eat right food, but still they were dying at 30, you know. Science has to advance, that is sure. So more molecules have to be found. And so in 1940, estrogen was marketed, and that later on led to bleeding. Then in 60s, the progesterone was added, but then progesterone was causing cancer. And so we need a drug which will not stimulate the breast, and a steroid that is tissue specific and do all that estrogen does. And then 25 years later, they found Tibolon, 1989. And he started extracting it in 1989, and it took such a long time. Finally, in 2004, they coined it selective tissue estrogen activity regulator. This particular molecule, the minute it goes to the liver, it gets converted to all, you know, estrogen, androgen, progesterone, everything. You have everything in one tablet, and that's one thing good. Reduces hot flushing, reduces bone resorption, improves karyotypnotic index in the vagina, improves mood. That is even good. No, nobody will say you are unhappy. You improves sleep, prevents loss of muscle strength, improves lean body mass, decreases proliferation in the breast. In fact, if you want to do a mammogram after estrogen, the mammogram will be like hazy. But when you do it after Tibolon, the mammogram won't be affected. So that is one thing. It doesn't affect the breast. It does. In fact, it will induce endometrial atrophy, you know. So these are the good points of Tibolon. It will not affect the cholesterol, lipoprotein, and lipoprotein levels. It lowers the HDL. That is one thing bad. It decreases the fibrinogen and factor 7 activity, increases antithrombin 3 and plasminogen, an overall trend towards increase in fibrinolytic activity. So cardiovascular, we really don't know. The dose is 2.5 milligram per day. So they are very smart. You know, they are saying you start Tibolon after 1 year and there will be less chance of abdominal bleeding. So if you do that with estrogen also, it will be the same thing, no? So it's not just Tibolon. Anything you start little later, you will have less abnormal bleeding. But if bleeding occurs, ask the patient to be reassured unless the bleeding is excessive or the endometrium is more than 5. Okay. So Tibolon it's supposed to be a bleed-free organ hormone, but yes, absolutely no, you can't say it. There can be bleeding. It does increase the risk of stroke, and it has to be used in caution with the patients who have had stroke before. It's not that instead of estrogen, you give Tibolon in stroke. It does decrease the body fat and increase the fat-free mass and total body water. Weight gain should not be a major concern. So you won't have your blouses getting tight with progesterone, you know? Especially when you have insomnia and all those things, loss of libido and everything. Tibolon is superior and can be an alternative to conventional HT for treatment of post-menopausal women with sexuality changes, which is very common because the men continue to have erections, but the women are never like, I don't want to have it. I don't feel like doing it. And the husband says, I can't marry again now for you. So this is a very common problem in very many houses. And also with Tibolon, there is less joint pain and stiffness and possible benefit in preventing muscle loss. That's good, no? You don't have to exercise. Reduce the DM and PMS, helps to attenuate abdomen. So this is all there. Now we come to what about diabetes? With MHT, in fact, insulin level will decrease, increase glucose disposal, and decreased abdominal fat. So in fact, it is good in diabetes. It's a no, not a no in diabetes. How long can it be used? In premature menopause up to natural age of menopause. Otherwise, the safety data is for 5 years and 7 years with estrogen only. But I've seen patients after 10 years saying, I can't stop it, what can I do? Maybe after 10 years, you can't tell them to take it. How long to give? Less than 5 years generally is enough, but some people are really addicted. After 5 years, generally the fluctuations in estrogen levels are over. And after that, they won't have hot flashes. And why use it after 5 years? So how do you follow up? You call them after 1 month and say, how are you? How are you? And all that. After 3 months, you look for weight and blood pressure changes. After 6 months or yearly, you just say hi to them and look at their liver, lipid profile, breast examination, BMD if required. So like keep in touch with the patient. No? And at 3 years, even you can do a pap smear mammography, just like that. So it's good to call the patient again and again. And you must understand that medications like calcium channel blockers, amlodipine, diltiazem, niacin, raloxifene, CC, all this can cause hot flashes. It can. So the DD of hot flashes is thyrotoxicosis, renal cell carcinoma, and all these drugs. So when a patient says, I'm feeling hot, think, is she hypertensive? Is she taking some drug like that? So you have to keep that also in mind. In COVID patients, you cannot give post-COVID, you cannot immediately give HT. Now, I don't know who is not COVID these days. So we'll have to stop using only. But but it is said that COVID is a procoagulatory stage, and so MHT has to be used with caution. And withdraw with systemic immediately after COVID. Either you use LMWH, heparin, or you have to stop it till she is out of the COVID situation totally. So bazidoxifene, you know what? When you give estrogen, it's a SERM basically. When you're giving bazidoxifene, the efficacy of estrogen is treating symptoms is there. And it does not stimulate the endometrium or breast just like the progesterone. So when you give estrogen at 0.45 milligram, much lower dose, and 20 milligram of bazidoxifene, it will reduce your symptoms without stimulating the endometrium, and you can use a lesser dose of estrogen also. So lesser chance of breast cancer without stimulating endometrium. So that is one up on the progesterone estrogen combination. So this is the fourth option other than Tibolol. Okay. So in a woman with premature menopause, would you use conventional HRT or OC pill? What is the difference? They say that randomized controlled study says that bone mineralization and metabolic effects are more favorable with MHT compared to COCs. Okay. So the rare absolute contraindications like endometrial and breast cancer, acute phase of myocardial infarction, undiagnosed breast lump, undiagnosed abnormal vaginal bleeding, and other contraindications are primary CVA, acute phase of PE, DVT, and so on. Now, if you're getting bored, please understand that you must learn everything, something new every day, even if you get bored. So thank you so much for your patience.
Thank you, ma'am. It was really a very informative talk.
Thank you. Thank you.
Ma'am,
sorry for the cough in between.
Ma'am, do you have any personal experience with sprays, estradiol sprays?
Sorry, with
estradiol sprays?
Yes, I told you, I had that patient who was having diabetes, uncontrolled diabetes. She was admitted and she was an industrialist or something. And I had given this and she was getting decreased symptoms, but she did not come for follow-up. It was much better because she had got high cholesterol and everything, and she was diabetic, she was hypertensive, and she could afford it. So I did give it to her, and she had decreased symptoms in 2-3 days. But after 1 month and all, they are supposed to come back. No, she didn't come back. I don't know. That company fellow had given it to her. That much I know. He didn't come back.
कितनी साड़ी sacrifice करनी पड़ेंगी मैम उसके लिए? कितनी साड़ी sacrifice करनी पड़ेंगी?
नहीं, 4,500 का ना लो, 2,000 का लो, बस इतना ही. Cost around 2,000 I think per meter dose. बस.
Thank you, ma'am. Thank you.
And if you are buying 2,000 का साड़ी लेती तो एक साड़ी को sacrifice कर. Even the other one costs 400, na? Even the other one costs 400, 600. So 3/4 of a saree, in fact. It's not even one. Yeah.
Thank you, ma'am. Thank you.
Good evening, Ambuja madam. Good evening.
ma'am.
Good evening to all of you. So nice to
Good
see
evening,
you all.
madam. Good evening, Dr. Ambuja.
Welcome,
Good
ma'am.
evening,
Welcome.
Dr.
ma'am.
Sudha.
Thank you. 10 minutes before a good chat always.
But madam, we are not 10 minutes late. We are the timing. You must have got it wrong. We started at 5.
You started at 5, huh?
Ah, you must have thought it is at 6. And she said 10 minutes before.
What is the time now?
It is 5:50. It's okay.
Fault तो हमारी है इसका
5:20.
मतलब. Fault तो
It's
हमारी हो
okay,
गई,
it's okay,
ma'am.
it's okay.
Is it
We have not
5:20?
given you the timing.
5:50, madam. Can we have the
Did-
chairperson's viewpoints? So
Dr. Richa?
after that, we will have Dr. Ambuja's. She'll let
Oh,
her-
I'm so sorry.
No,
I
it's
thought-
okay. At least you came. No, at least you came.
Excuse me, excuse me.
Oh, no, no. We are
I was just thinking it is time, so I thought it is 5 o'clock. I joined.
Dr. Richa, give your closing remarks.
Good evening, good evening, Dr. Shobna. Good evening, Dr. Jignesh, Dr. Sudha, Dr. Anju, and Dr. Ratna.
Dr. Kiran,
Very-
Dr. Richa is also speaking and she is unmuted.
Acha.
I can see her lips moving.
Oh, Richa is speaking,
Ma'am,
so I'll.
Ma'am has wonderfully summed up MHT. She has given us the age group where we can give it safely, the different routes which can be given in those patients who are who have other comorbidities, and also that how this is much more important than our other expenditures like on sarees and jewelry. The spray, which is actually the spray, the availability of the spray in our country should be more, because this is not freely available, probably because of cost. And she has also explained how the new progesterones are much better with the fewer side effects of bloating and weight gain. And we do need to keep our patients on MHT on checkups, which may be 6 monthly or yearly, but they should be meeting us from time to time so that we can diagnose if any other side effects or complications are occurring as a result of MHT and when to discontinue it in that patient. So ma'am has
Kiran?
wonderfully told us the different regimes also, and the different preparations and the advancements in the progesterone which are available now. Thank
Sudha
you, ma'am,
madam.
for a wonderful session.
Thank you, Dr. Richard.
Sudha
Kiran
madam is
Pandey?
also there. Sudha madam can also.
And
put-
gel also is available nowadays. Gel.
Yes, 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 madam.
Sudha madam, you
also
please
available.
give your remarks. Sudha ma'am का पर कुछ
The voice is getting broken.
मैडम का काम नहीं कर रहा वाईफाई या वाईफाई is not working much.
Yeah, her image is still, it's not moving.
Dr. Kiran, you can speak, please.
Yeah.
Dr. Kiran,
Yeah. I'm there. I
Hari
was
is
just
also
waiting
sick.
if Dr.
Hello?
Sudha is there. Am I audible?
Yes, ma'am.
Yes, ma'am. Yes, ma'am.
Yes. Thank you, Dr. Ratna, for giving me this opportunity.
Thank you, ma'am.
And
privilege,
it
ma'am.
was really
There is one
wonderful.
question in the chat box.
Yes, madam, I'll just inform this. Just before that, I wanted to share that Dr. Dr. Shobna has given such a wonderful talk. There is a quote which I was remembering all the time in Hindi that is called Gagar mein Sagar Varna. Like in a very small vessel, you are filling up the whole sea. Like MHT is one subject. There's whole books are on that, and you have filled into one lecture of 30 minutes everything into it. So very nicely you have told. And the beautiful thing was about those comparative tables, which I actually, the efficacy of the different estrogens, the youngsters which have to start using or they are not using, they should be very careful about it. What is the potency when you are using it? Should not write it casually. That's very, very actually important message. Maybe estrogen, maybe progesterone, both. Like one thing, she has a very special capacity to present it with giving good examples of the practical use, making it interesting, and patient could be like, if we explain it like this way, they will very nicely understand. But idea is basically that I think the message, most important message is MHT is not something hawa. One has to use it, but judiciously. Because of the WHI that study, there has been a concept into everybody's mind. Everybody is scared to use it. That is why
Okay, madam. Now we are running
understand.
out of time because Anju has to talk.
Yes, thank you, Doctor. Thank you,
madam.
Dr. Shobna, for giving it. Wonderful talk.
Thank you.
I missed Shobana.
There's a question, Madam Dr.
Oh.
Shobna. Can MHT be given in a 54-year postmenopausal patient, surgical menopause? That
I suppose
total
so.
abdominal hysterectomy done 12 years back. She's diabetic and hypertensive.
Yes, you can give it because you're saying 55 is the age group. So you are just jumped the gun, and 54 means maybe you can give it as.
And it is good for diabetics and the hypertensive if it is controlled, and best like the lowest dose.
Yeah, start with lower doses. Try using that continuous preparation, dihydrogesterone and estrogen with very low dose.
Yes.
And if that works, then that's good enough. It will improve the diabetes, in fact. And hypertension also, unless a stroke or anything, triglycerides are not more. You can take oral also. Triglycerides are more. You could switch over to the gels. Okay. Yeah.
Thank you, Dr. Shubham.
I invite Dr.
Anju.
Ratna ma'am to welcome Dr. Ambuja ma'am.
Thank you.
Ambuja ma'am. What to say about her? I love you, ma'am.
Thank you. Thank you very much.
Dr. Ambuja ma'am, who is a past president of IMS, who is always a pillar of IMS. She is very intelligent, smart, knowledgeable, talented, and very hardworking. And above all, very affectionate.
Ratna. So don't read. So many times we read. No, I think we'll go ahead with the scientific things.
We welcome you, ma'am.
Thank you, Ratna. Next person, whom I should introduce? Who is the other chairperson?
I'm Dr. Aarti Gupta.
Yeah, Aarti.
कौन बोल रहा है रत्ना जी?
हमने पढ़ लिया कि she is the chairperson of Indian Menopausal Club 35 plus. सबको ताजमहल दिया है वो Club 35 की ओर से.
We welcome Dr. Aarti Gupta as our next chairperson for the next talk. Dr. Aarti Gupta, as we all know, is chairperson of Indian Menopausal Society, Club 35 plus, and Public Awareness Committee. Publication voice. Yes, ma'am.
Everybody knows, no problem.
Okay, ma'am. Ma'am, may I please invite you to welcome Dr. Anju Soni, ma'am.
I welcome Dr. Anju Soni, ma'am. As all of us know, she is Secretary General of IMS at present, and she is chairperson HIV and AIDS Committee in FOXY. She is president of Jaipur Obs and Gynae Society in 2018 and 19, president of Jaipur Menopause Society 2017 and 18, committee chairperson Public Awareness Program IMS, vice president of JOGS 2013 and 15, and so on. Anju ji, बहुत सारी आपकी उपलब्धियां हैं. I welcome you. Thank you so much for your introduction. I think we can continue further. आगे चल पड़िए.
Yes. Over and again, beauty and.
Can I share my screen, please?
Ambuja ma'am, namaskar. Namaste.
Please share your screen, ma'am.
One thing I can tell about Anju, beauty and brain together acting here.
And that is true, but that is undisputed that all our present delegates are beauty with brains.
Oh, उसमें भी superlative degree रहता ना वैसा.
हाँ, मैम IMS का ट्रेडिशन है कि जनरल सेक्रेटरी जो है ना वो B2 होता है.
Yeah, well said, well said. Well said. Who is that? Kaya? Yeah,
Ratnashali,
it is.
Ratnashali.
Yeah, it is good. It is correct. And that too, we have sweet memories with Agra always. And ASUOG, which we attended in Agra, it was again superlative. Kabhi nahi dekhe utna acha. Decoration and food and all is very good. So that's what is the Agra people.
Thank you for your
Thank
kind
you, ma'am. Thank you, ma'am.
Anju, go ahead. Of course, जयपुर के बारे में हम बोलेंगे 25th और है ना आपका celebration हम आ जाते तब.
You're welcome, madam. Is my screen visible? Hello? Is it clear?
No.
Am I visible and audible?
Yeah, you are visible and audible.
Huh?
Yes, ma'am.
Yes.
And audible also?
Yes,
Your
yes.
voice is not clear.
Yeah. Can I go the?
Not clear.
Just come a little closer to the
Huh?
mic.
आवाज clear?
No, ma'am.
Your
Not
voice is breaking a bit. Your voice is breaking, ma'am.
एक second मेरा पूरा.
चालू करो देखते हुए whether we can hear you. Start. Meanwhile, I will welcome all of you to IMSCON Calicut, which is there in February 2023. You will have the scenes of Kerala. Wayanad is a hill resort nearby. So you can combine that with the academics in Calicut. So all of you keep your dates free and don't go anywhere else this year. Come to Calicut IMSCON.
So, Shobana, Wayanad is the name of a place, is it?
Yeah, that's a hill resort. It's a hill.
Oh, resort.
Yeah, 2 hours journey from Calicut. Okay, okay, Anju.
Am I audible now?
I think why don't you speak and put off your video? Maybe Wi-Fi is not good. So you put off your video and talk. Then we'll get a proper voice.
Okay. I will do that. Okay. Yes, my internet is bad.
Yeah, that's right.
Yeah. So, am I audible now?
Yeah, you are audible.
Yeah, so welcome Agra and congratulations Agra for organizing such a beautiful CME. And after listening to Dr. Shobna's talk, my work has been already and it will be easier for me to go further. So while I go through my regarding MHT with comorbidities, I'll be touching almost everything, little. When should we avoid MHT altogether? Whether we should give in cases of endometriosis? What about MHT with fibroids, heart disease? What are the regular causes for MHT? Is there any role of MHT in Parkinsonism, renal failure, transplants, and some special situations? And of course, MHT in diabetes, which has been very well covered by Dr. Shobna, a little bit about that. And then MHT with migraine. And of course, MHT with different carcinomas like breast, endometrium, and ovaries. So when should we avoid the MHT completely? Whenever there is an unexplained vaginal bleeding, or there is a history of stroke, TIA, MI, or PE or VIT, or there is a history of breast and endometrial carcinoma, which is in advanced stage, or a patient is having active liver disease. So if a patient has got cholestasis, as Dr. Shobna has already said, that it increases the liver problems and cases of gallbladder stones increase.
So whenever there is cholestasis or hepatic adenoma, we have to avoid MHT. What about SLE? There is evidence that that there is risk of flares, but there are still no RCTs available. So when whether we should avoid in porphyrias, yes, these are the porphyrias and the precursor of heal to CNS and skin disorders. We know porphyrins are very problematic, and it can have abdominal pain, chest pain, vomiting, confusion, constipation, fever, and even hypertension. And estrogen and progesterone are supposed to exacerbate the attacks, so we should avoid it completely. Now, what should be the choice of MHT endometriosis? This is again a very big problem, which people don't know, and people don't, because it differs than normal MHT. So let's start with a case of a woman who who's a high profile, 50 years, underwent TSBH, so for a bilateral endometriomas 2 months ago, and she presented hot flashes. She was given alternative therapy like soya and tofu, no relief. She came again. Clinically, everything normal. Now, should her ovaries be removed? That is first question. If yes, why? If not, why? We all know that ovaries continues to produce androgen after menopause, which are very, very useful for not if for bone health, mood, and libido. And we all know that tubes have to be removed because it can lead to hydrosalpingo, and it is said to increase the chances of carcinoma ovary. And what should be the management? And after counseling this patient, we choose to give her hormone therapy. And what should be the regime and what would you give? Let us talk about that. We know that post-endometriosis is a condition which is very painful. We are forced to do hysterectomies, no oophorectomy. And should we routinely put them at HRT? Yes, when they are symptomatic, we must. Because endometric implants are present even after hysterectomy, so progesterone protection is necessary. So we have to give them a combination therapy of estrogen and progesterone or tibolone, as Dr. Shobna has explained everything in detail, so I'll not go into detail. And this should be given up at least up to the age of natural menopause. Now, what about HRT with fibroids? Again, this gives rise to lots of dilemma. There are, of course, no good studies still available, and it has been shown to decrease the rate of fibroids in a woman with HRT. And some studies have shown that there is increase in size of fibroids, but such women are not symptomatic. So a 3-year study showed that the women with or without fibroids were given HRT, and in first 2 years, the volume definitely increased in this group, and third year, there was no marked increase. And at the end of third year study, 34 and 3 out of 34 women, there was increase in fibroid volume, over 25% compared with baseline, vis-a-vis of non-users and users respectively. So we must, weigh, because the size definitely increases, but the symptoms are controlled, but there is no side effect. So we must give them in cases of symptomatic women and watch them closely, maybe 3 monthly and 6 monthly. Now, what about hormone therapy in hypertensive patient? Dr. Shobna is very well explained, but just to recapitulate that, 60 women were given of hypertension were given whose blood pressure were recorded around the age of 50, and then transdermal continuous HRT in sequential regime was given, and placebo was given, and they were followed up for 3 to 6 months, and there was no significant variation in systolic and diastolic measured. Standard sigma was detected. So 24 hours BP was less in treatment group, and there was decrease in daytime BP, which was significant in both systolic and diastolic. Now, this is because of the estrogen. It leads to vasodilatory effect. It leads to increase in bradykinin, and there is increase in nitric oxide. And all these things combined together are beneficial for improving hypertension. It has already been said that since the dose of estradiol is 4 times higher than the normal dose indicated, should not be given. So these are the studies. And then heart disease is another dilemma which we need to deal with. A woman who is 47-year-old came with multiseptated 15 ovarian cysts with 5 centimeter fibroid. This is a practical case which I have dealt with. She had only edema feet, and as a complaint, her hemoglobin was 7. She was scheduled for LAVH with BSO, and routine checkup showed to be having a left ventricular dysfunction. She had BSO, and she is put on hormone therapy prophylactically. If she develops HRT after she being diagnosed as LVH, another woman, she is a case of CABG, CAD 2 years ago, and she complained of night sweats, nocturia, frequency, urgency, joint pain, backache, and her urine showed, WBCs, culture was no growth, and her sugar was 100, fasting with 102 and 106. Her BMD T score was minus 1.8, and she was on hormone therapy before surgery and wants to go back. So what should we do? We can give her lifestyle management and a vaginal estrogen cream, bisphosphonate, or hormone therapy. These are the questions. We all know that in cases of surgical menopause, routine hormone therapy is not recommended. When it is done, when she's on the age of, she's at the age of natural menopause, and it can be only given for primary prevention of chronic conditions if within either 55 years or 10 years beyond, and should be considered only for a woman who are less than 50 who have gone on surgical menopause. Now, the heart failure is need not to be contraindication for HRT if she is severely symptomatic. Now, this is another study which was done for a patient who were patients of heart failure, and they were on this beta blocker, and other were on placebo, and these were about 435 women above the age of 50 years and older, and 102 were using HRT, and 333 were non HRT, and 21% of these patients died, while 30 in the HRT group only no HRT group there were 34% more death, which shows that there was no significant difference in survival favoring HRT use. So far, HRT can be given in pre-menopause as far safe for hypertension, and it is if it is started first time in woman who is more than 10 years post-menopause, it can be detrimental, and in hysterectomized patients which are more than 55 years, we have to weigh the whether it can be given or not, and then we all know that lipid-friendly progesterone is always better to be used in these cases. Now, there is evidence is that hormone therapy for secondary prevention has got role, and secondary prevention of CAD should be done by non-hormonal methods. Now, there are some cases where patient comes with irregular bleeding, and you think, what has happened? What has caused this irregular bleeding? And it can be alarming for both patient as well as the doctor. So we must remember these things in mind. There are cases of irritable bowel syndrome or Crohn's disease or celiac disease, which can lead to poor absorption of drug and further leading to irregular bleeding. Then thrombocytopenia, or a patient on one disease, or a warfarin in high dose, or a dose of high dose of aspirin, can again lead to irregular bleeding in MHT. Another condition, a patient is on high dose of antibiotics. Because of this, there is intestinal hurry, and there is poor absorption, which can further lead to poor effect and irregular bleeding. Another case of problem which may come to us is that a patient may come to us with asthma. You don't know whether you should give her the MSG or not. It has been seen that there is small increased risk of and no worsening of pre-existing disease. So we can prescribe them in a woman who are symptomatic and who really require treatment. Again, a patient of renal failure should be given. It is found that there is increased risk of early menopause in this patient, so it should be avoided in cases of renal failure. Then Parkinsonism, it is said that it may reduce the risk of Parkinsonism, and it is not contraindicated in this patient. Rheumatoid arthritis, we all know, we just heard Dr. Shobna, it is supposed it is beneficial. Then again, venous thrombosis, we prefer to give either vaginal estrogen or transdermal estrogen, and other MSG is contraindicated. Then again, thyroid disease, it is not contraindicated, rather thyroid hormone, it should be given because thyroid hormone speeds up bone resorption. So this is a special situation where it's considered. Then another, dilemma occurs when a patient is having any kind of transplant, a post bone marrow transplant, because the patient or prior chemotherapy prior to transplant, which can lead to destruction of ovarian tissue, and thus there is premature menopause. So there is graft versus host disease, and along with vaginal atrophy, it can even lead to occlusion of vagina. So we must give them local estrogen, and we must keep these patients in mind. Another post-renal or hepatic transplant, there is bone mass loss is very, very rapid, especially increases within 6 to 12 months after transplantation of vascular-related organs, and immunosuppressants are responsible for this, and parathormone is also elevated in these patients. So women with are given combined estrogen replacement and therapy have significantly lower level of then we are talking of the diet, in a patient who is fasting glucose and HbA1c is good, and dramatic reduction in plasma total cholesterol and density of lipoprotein, increase HDL, and women with HRT have lesser chance of diabetes. This is just to collaborate or summarize, and women with HRT have better control of diabetes. Here I would like to share that I had my hysterectomy at the age of 51, and I had severe symptoms, and I had a very, very strong family history of diabetes. I went from pillar to post, all, that time this must be about 15 years back, I talked to each and everyone. Everybody said, no, you should not take. Then I suffered and I could not take HRT that time. But now, with knowing it so much of detail, I know that I should have taken HRT and not suffer the way I suffered in my life. And so, to summarize, that heart failure and hypertension are not the contradictions for MHT. And the woman suffering with hot flashes, there is no law of rule can be prevented for HRT diseases with MHT, and patients on transplant and rheumatoid arthritis will benefit from MHT, and fibroids are not a contraindication to MHT. Then again, diabetes and MHT, let's revise a little bit of this. MHT improves glycemia, and they are the excellent candidates, and women with diabetes can be given MHT oral if they do not have CVD risk, transdermal if they are obese or if they have moderate CVD risk. And there is a lack of evidence around the use of HRT in women with type 1 diabetes. Of course, the transdermal and sprays are considered better. Now, a woman in her early post-menopausal age has a history of migraine. Let's come to migraine. What will happen to her migraine after menopause? We must know, because this is one of the very big problems. Will she require, if she needs HRT, how can we give it? Low level of estrogen and high level of FSH. There is a lower prevalence of migraine after menopause, and there is absence of variation of hormone in post-menopausal women. Because of this, estrogen withdrawal can lead to migraine. So this is a situation where patient may have improvement, some of them may have migraine because of this. So sequential regime again can cause migraine. So continuous HRT or transdermal is the indication in this patient. Again, a lady came with, she was operated for breast cancer, and within 6 months she went TAH and BSO because of risk of ovarian malignancy. She complained of severe vasomotor symptoms and vaginal dryness and dyspareunia, loss of libido, and how to treat, which is the ideal dose estrogen to be given. A 46-year-old healthy female presents with complaint of severe insomnia, mood changes in last few months, increased emotional fallibility, crying outbursts, complaints of palpitation, fatigue, giddiness, insomnia, once in 6 months, experienced difficulty in falling asleep for many years, particularly in a week prior to a menses. When she usually feels weird about going to bed, worried, irritable, about everything, cannot turn it off, and during this time, it usually takes half an hour or even longer to sleep. She has also suffered from mood changes in premenstrual period. These are the few cases which we come across almost every day in our day-to-day practice. She never thought treatment because it was not severe enough to affect her job or concentration the next day. It would go away when the periods come. So last menstrual period was 9 months ago. Her FSH is high, her hemoglobin is low. She was seen by neurologists, cardiologists, gynecologists, referred to psychiatrists. How do we manage such a patient? Now, in this case, when we look into the detail, we see that she's got anemia, she's got anxiety neurosis, and she's got perimenopausal syndrome. So, in these cases, we should treat her with hormone therapy and fluoxetine, or with fluoxetine once OD, and along with hemodynamics and lifestyle modifications. Then again, coming to non-hormonal treatment, first about hot flushes, it has been explained very well that non-hormonal has been to be given in this patient as first-line treatment with either paroxetine, gabapentin is also very effective, and blood pressure, for blood pressure, we have to give a clonidine, vitamin E, and patient is on tiroxine and are less effective. Now, another very, very common problem which we face in our day-to-day practice, though it is not concerning, but I would still like to touch this, dense breast. A 46-year-old healthy woman, a para to breastfed, and complains of few hot flashes, night sweats, insomnia, mood changes, loss of libido for last 18 months. Her periods were 10 months ago. Her premenstrual, she gives history of premenstrual breast pain. Her breast cyst was aspirated about 3 years ago. Screening mammogram shows benign dense breast, and after WHI, report, she refuses to have hormone therapy, preferring non-hormonal treatment. But she was unhappy with the relief. She came back for consultation. So, would you offer hormone therapies? This is a very, question which comes to everybody's mind, even your mind. There are fears that her close friend had breast tumor. She was afraid that her cyst would produce pain and neoplasm. Although she did not want irregular bleeding, she's willing to accept regular, predictable vaginal bleed. So, because her motivation is flushes in night sweat and bad sleep and mood, loss of libido will improve. She will have good interpersonal relationship. She will regain normal performance at work, and of course, MD will increase. So, which is the preferred option in this case? There are a whole lot of a bouquet of, therapies available for her, like combined cyclic hormone therapy, who continues to oral, but we all know that loxapine, phytoestrogen, fluoxetine, clonidine, but Tibolone is in this patient is the best option. We must give her this. Then again, coming to hormone therapy in breast cancer, there is no clear evidence that hormone therapy causes breast cancer. Overall risk of breast cancer while on hormone therapy is very low. Women who develop breast cancer while on hormone therapy have a better survival rate rather than not on hypertension, and a family history of breast cancer does not further increase the risk of breast cancer while on hormone therapy. So, what are the risk factors of breast cancer? We all know that is risk factor is dense breast because we are not able to diagnose. The non-modified risk factors are age, family history, benign breast disease, BRCA, career like 1 or 2, and early menarche, late menopause, increased breast density, and chest radiation between the age of 25 to 55 years. Modified factors are age at first child, breastfeeding, parity, obesity, which can be avoided, and physical activity, and decrease in alcohol. Again, coming to another cancer, which is again give us a dilemma. A 40-year-old patient, para 1, living 1, active in politics. She has type 1, stage 1 type 1 endometrial carcinoma. She had TAH with PSO 6 months back. So the recommendations are that since she's got a low grade, early stage of time, we may consider MHE as indicated. But in cases of high grade and advanced disease, it is an unfavorable history of histology, which is type 2 carcinoma. Non-hormonal treatment should be preferred on the MHT. Then again, another dilemma for treatment is the ovarian cancer. Mrs. Vani, 39 years, diagnosed with carcinoma at stage 1B, grade 2 clear cell carcinoma during diagnostic laparoscopy for infertility. Frozen section, fluid analysis, TH with BSO with omentectomy, staging left done, postoperative chemotherapy was given. She was asymptomatic for menopausal symptoms, high risk of CVD, mild hypertension, on atenolol, raised triglyceride. Mother has stroke, BMD was normal. The issues were she had premature menopause and she had cardiovascular disease. Now, we all know that in cases of premature menopause, hormone therapy can be prescribed natural menopause. Further continuation of therapy is a shared decision between woman and physician. According to indication and need, this is grade C evidence. Now, MHT you would use after ovarian cancer. For different cancer, we must know that MHT is indicated in a prior epithelial carcinoma, advanced disease, serous or endometrial type, because they are all estrogen responsive positive tumors. Then sex cord tumors, they are estrogen positive, limited evidence. Germ cell tumor, it is indicated. Meta-analysis, 2 RCT and 4 cohort studies show that MHT is not associated with recurrence and regardless of cancer type of MHT on the patient. Thank you very much for patient hearing. I hope my bandwidth was not bad that I could not, I was not audible. Dr. Ambuja, was I audible?
Yeah, you are audible. Manju, you are audible.
Yeah, thank you.
Thank you, ma'am. Thank you for the presentation.
Manju, it's a very good presentation.
I can't start my video. Can somebody tell me how to start the video? Yeah.
No, you can start your video. It doesn't matter even if your voice is dragging.
Yeah.
Yes, thank you.
It's a very good presentation. You did not leave a single comorbidity or the disease. You in 15 minutes you covered everything, especially that endometriosis, which is Shobhana's slide. It is there.
Dr. Shobhana's slide.
Yeah.
She gave me
Madam, first half of the whole presentation is Shobhana's slides.
Yes.
Second half is Anju's.
Presented by Anju.
The first second half is Anju's.
But whatever it is, it's a very good presentation. You covered all the topics, and in a nutshell, this is really good and very useful to everybody, because it's like a reference what to do, whether to give or not. Ting, 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 ting. You covered everything. It's very good. Congratulations.
I would like to thank Dr. Shobhana for this. She gave me lots of input. Thank you, Dr. Shobhana, for your inputs.
But you added all the cases in the second half, all those cancers. From where you got those cases? कहाँ से उठा लाई?
अरे उनका ही रहता, 40 years experience में cases की कमी क्या रहती?
Yeah, but then you have to write it down immediately. That's very nice.
One thing which I really suffered for about 5 to 7 years was hot flashes myself.
And I talked to be बोल दिया.
हाँ, बिल्कुल. I really suffered so much hot flashes, you can't believe it. And everybody, everywhere I went, so no, you can't take. I said, can I take Tipulon? No, you can't take. And I suffered and suffered and suffered.
अरे हमसे पूछना था, क्यों भूल गए? हम बोलते थे.
Madam, but
15 years back.
Electronic registry तो रहता ना तुम्हारे पास. See, when you have a nursing home, all the cases will be recorded.
I talked to Dr. Sunila, Dr. Mita, each and everyone. They said, no, you should not take.
I mean, they see the concept at that time, it was different. And now the concept is different. And the HRT, the one which is changing every time. 22 today is like that. Maybe next year itself we may change all these things and say
Of course. That is what I'm saying.
contradicting point, we may say. That is why whatever statement we are doing, it is on today, it is like this. I think MHT is the one which is changing every time like this. It is not like folic acid where we are using it as the prophylactic medicine for the prevention of neural diseases. It's not like that. It is, yes, whoever wants, whatever you want to say, there is no contraindication for everything we say.
One
But
more thing,
HRT is
madam.
not like that.
Madam, one more thing is that, Dr. Shobna has very well chosen the topic of hot flashes. Most of the women do not even give us the history of hot flashes. You have to really dig out the history.
Yeah, again, that is is about 10 years back, it was the trend. Now people are coming forward to say that they have the hot flashes. Because the question comes when the patient is 65 or 70 years and complains of hot flashes. These things, they say that you should not give it, and how to treat them is another problem for us.
I have a lot of patients who are from a poor background. Some practices with poor patients. So those are the patients I really have to dig out, about their complaints, and it is really, really eye-opening to see that so many of them are suffering, and they feel it to be a part of aging. So we need to really tell them, and especially in Rajasthan, in some parts of Rajasthan, the hysterectomy is done at the age of 25, between 25 to 30, and that also by RMPs and surgeons, and they remove their ovaries then and there only. कि तुझे बाद में भी तकलीफ नहीं होगी, हमने तेरा सब कुछ निकाल दिया. That is what, everything has been removed. The ovaries are also removed. So those are the patients whose women, and they also go for hysterectomy, because in Rajasthan men don't work. They just sit and chat, and the women are made to work in the field 24/7, and they know that if they get their
It happens in Kerala also.
Men have to go to the farms, so they get their hysterectomy done with no reason for hysterectomy, and the surgeons sitting at periphery and the RMPs, they are just removing their uterus and ovaries left, right,
and you be happy. At least it is for the hysterectomy bonus, they have removed the ovaries. But even for appendicectomy, they say it is nearby, unko bhi nikal do bolke, ovaries nikal dete. Surgeons are like that, so you should never go to surgeon for hysterectomy.
So I hope we can put it in bold letters in the country.
We can, why not? So many times I presented, said
नहीं सुधार सकते, इतने RMPs बैठे हुए हैं, जगह जगह खोल के थैला छाप सर्जन को बुला के hysterectomy कराते हैं. किस लिए कराते हैं? नेपोथियन सिस्ट के लिए hysterectomy हो जाती है.
My God, that's terrible.
Change the topic.
Yes, madam.
Change the topic. हो गया क्या अभी? और कुछ?
छाले हो रहे हैं and removed.
But well organized
yes, madam, it was
webinar, and speakers are very good. Congratulations.
Madam, I want to ask one question.
Yeah, मेरा भी 2 questions है. आपके बाद मैं पूछती हूँ.
Madam, आप पहले पूछिए.
Why? अरे पहले तुम, पहले मैं, चलो जी पूछो.
Before I ask the question, congratulations, Dr. Anju, for a wonderful program. Like you, very crisp, you said, discussed every comorbidity. I was just wanting to know, supposing like an endometrial carcinoma or an ovarian cancer, very specifically, you told where to use MHT and where not to use. Supposing we do follow this, I'm just presuming if like a patient comes and fulfills all those limitations and needs it, we give it. Later on, some problem, like malignancy is there, so that will increase. And the patient medico-legally puts you into an odd situation by complaining that it has happened because of your treatment, because it is written in book or in the Google, a person reads. So how do is there any, like in our society, this way somehow, those are the, our Dr. Shobna as a president is there, Dr. Ambuja past president, Dr. Jigdesh also past president. So what do you suggest if something like this happens? How do we will, a general practitioner will save, general practitioner or menopause practitioner will save oneself?
Nothing
from
to
such
save
type-
in that. If that's where there are clear-cut guidelines and you're using it according to guidelines, cancer can recur with or without HRT. So you can just tell them it's not because of HRT. She said, now later stages of endometrial cancer you can't give. Earlier ones you can give.
Yeah.
So there is
One
nothing
thing-
wrong in it.
One
Let
thing I'll tell
cancer
you,
recur.
anytime you are giving such a controversial thing for any cancer or anything, take a written consent. That's very, very important. Second,
No, but then
counseling.
what consent do you take that you know that it will cause cancer, but it doesn't?
No,
How can you take a
we
consent?
do explain that this is what is the thing, these are the guidelines, this we are giving because we are having such a desperate condition. So you have, unless you accept, we cannot give. And second, you should have a sound knowledge of what you are giving. Third is put the guidelines and show that this is the guidelines, it says like that. And American guidelines are like this, Cochrane is just
Unlikely.
like this.
Anyway,
Whether they
Dr. Kiran,
understand or not, it is our duty to tell them that we have done it. And second thing, what I do usually is, whatever I tell, while talking, I'll write it on the case sheet. Even if they bring it after 10 years, even if they say that I have not explained, it will be there on the case sheet. See, you make it a point, just write down, scribble it, whatever you told. That really saves you. Make it a point. That really saves. And second thing, Anju, somewhere I saw your slides. In hormone therapy below 50 years, immediately after hysterectomy, without any complaint, is it advisable?
no.
I think in one of the slides I saw that you are
No, it's not there. No,
routine hormone therapy.
No,
Below
routine
50
hormone
years,
therapy is after endometriosis, yes.
No, not that. Below 50
No,
years.
madam. No, it's not.
No, it is not written, is it? Then I am sorry. And what about the thyroid patient when you are giving the hormones? Do you like to increase the thyroxine level?
No. Why should you? It's just that when patient is on thyroid, she is more osteoporotic. So
And
it's more
TSH
indication for
level-
giving HRT. That's all. Why should you increase thyroid levels?
Yeah, when we are investigating a postmenopausal level, women, we will not have the cutoff point as 4 or 4.5. Even up to 7, asymptomatic up to 10 is normal.
That is
we don't
something
treat.
different.
That we should understand.
Very
because
important.
of the increased gonadotropin levels, which have got the alpha and beta subunits, which are similar to the TSH. TSH level will be increased. So never treat a patient if it is asymptomatic up to 10. If she is asymptomatic, treat 7. 7 is not at all an indication to treat, because many a times we see prescriptions, they treat 5, 6, 7, 8. So that I think we should give this message to everybody that not to treat up to 10 asymptomatic.
Yeah,
I
that's
think
a very good
Anju is not
indicator.
heard.
No.
Yeah, I am saying that we must, this is, because why I am telling you that so many times our anesthetists also say your patient is hypothyroid, the thyroid is not controlled. So they also be told that 7 to 10 in this age of group of women, around 40, 50, if we are doing a 50, 52, it is not to be worried. We can
It is
always,
normal. Yeah, it is normal.
Yeah. So recently only I operated about 5 to 7 of my patients who had TSH about 7 to 10, between 7 to 10. So they have to be told, because so many times they say, so your patient is hypothyroid and control it, and then. So if it is an emergency, and plus these patients don't require any treatment.
Yeah, but Anju, the anesthetist, they always take their
Yes.
view. They say, head and pay, we are there and we have to handle the complications. So they
What
usually do
complications
not
they have to handle with
Yeah.
thyroid? ऐसा ही बोम करते हो लोग.
Yes.
So it's a good webinar. Congratulations to all of you. So shall we take leave?
Thank you, madam. Thank you for being there. And thank you, Agra. Thank you, Dr. Shobna, Kiran, everybody.
Thank you.
And
Thank you,
all
Agra,
other
for holding this
society, the
webinar.
present
And
Aarti,
fairly good attendance also. I was very
everybody.
surprised.
Yes, ma'am.
मैडम आपका लेक्चर एकदम MHT was there
शोभना का लेक्चर था ना
दिमाग में
तो but
शोभना
MHT
का लेक्चर
कितना बार
था
हो
ना
गया
आ
है?
गए so
Both lectures were very good.
good day to you all. Bye bye.
Thank you, ma'am. Thank you, ma'am. Thank you so much.
Hi, Ratna.
Thank
Thank
you,
you,
Dr.
ma'am.
Ratna.
Savita.
Thank you,
Namaskar,
Dr.
Okay,
Ratna.
bye
Namaskar,
everybody.
Shobna, Dr.
Bye,
Ambuja.
Thank you so
everyone.
much also. We are closing here. Thank you.
Thank you, ma'am. Thank you, everybody. On the behalf
Bye.
of the Menopausal Society, I thank you all. Our guest,
Sudha Bansal.
thank you, ma'am.
All
Okay,
Sudhas are
bye.
very sweet looking.
Thank you, ma'am. Thank you.
Thank you, ma'am.
Bye.